Hello. Hello, hello. How you doing, Ryan?
I'm good, Chris. How are you?
Good. You're not Liz.
I am not Liz McIngvale. Liz is actually out on vacation. I work with Liz very closely. We actually work at the same clinic, the OCD Institute of Texas. I'm the clinical director here and work very closely with her treating OCD.
Yeah. Well, welcome. Thank you so much. Yeah. So for everybody watching, Liz McIngvale will not be with us. I'll try to figure out a way to get her on. Maybe she'll join me with a psychiatrist next week. Actually, no, it's April that has 5 Wednesdays. I'll talk to Liz. We'll figure it out. But you will get your fix of Liz for sure. So yes, we'll figure it out with Liz. But it is great. One cool thing about Liz is that she can't make it. She always throws me somebody who has great expertise, who is a friend to the show, somebody I usually know. So that's always kind of nice because if I don't know, it's like, hey, for the first time. But Ryan, I've met you at conferences, I think multiple, plural. Yeah, and you're holding it down out there at the OCD Institute of Texas. So besides working with Liz, like what got you into OCD? What kind of got you interested in it in general?
Yeah, that's a great question. I've been doing this for about 7, 8 years now, clinical work, over 5 years specifically in the OCD world. I also have lived experience with OCD and anxiety, so something very close to my heart, something that I'm very passionate about, and also the idea that changing the narrative around OCD is something we have to struggle with forever, and really pushing for. No, we want freedom over functioning, which is something that you guys know Liz talks a lot about. And so I'm behind her 100% in that mission and the work we do here, and the work that IOCDF does. So that's kind of what got me into this. And then, of course, I just love working with people with OCD and the related disorders. You and I both work a lot with BDD. I like doing a lot of work with body dysmorphic disorder. We can talk about that later too. But yeah, I love this work. I love ERP. I love seeing people do hard things. I love seeing the feeling that people get when they do hard things, things that they didn't think they could do. It's incredible. It's a rush for me too. So yeah, I love this work.
Somebody said Liz has changed her appearance. Yes, Liz decided she was going to cut her hair short, dye it, and get a mustache. So yes, Liz. Well, the cool thing, what I always like is, I have Liz and Kim Quinlan every month, the psychiatrist guests on. So my hope is, I always tell my clients this because I run support groups. And sometimes I can't make it to the support group and I have to have somebody else run it. Not very frequently. I probably do like 98% of the groups the year, but sometimes other clinicians come on, and it's so funny because somebody will say, I'll ask them like the next group, like, how did it go? And they're like, oh my God, it was so amazing. Like she said this thing and it really clicked. And I'm like, I've been saying that to you for 2 years. Sometimes like somebody else will say something in a certain way or use a certain verbiage or something that just has us kind of like click in our head. So that's why I always like having different guests on, because it's like, oh, sometimes somebody will say something that other people might have said, but they say it in a way, or they use an analogy, or they give it a different perspective. So I always like that. But I'm super excited to have you on, Ryan. You're obviously a licensed clinician. You have lived experience like myself. This is great. We're going to jump into a little bit of back and forth before we get to questions. But welcome, everybody. This is your Ask the Experts. We got Ryan Judd on, stepping in for Liz McIngvale. We'll figure out how to get Liz McIngvale on the live this week, or this month, rather. So you don't have no Liz, but she sent a would you call yourself like her right-hand man? I mean, you're the clinical.
Yeah, I would. We work. I'm like her work husband, right-hand man. Yeah, we run the clinic here. And,
I used to be called her work husband when we did these 4 times a month. So I'll pass on. I'll pass on the term. So,
yeah, that's right. Her California work husband.
Yeah, I like that. So welcome, Ryan. Welcome to live stream. So if this is your first time to live stream, the International OCD Foundation has live streams, and we are currently broadcasting on Facebook, LinkedIn, YouTube, Twitch, X, as well as iocdf.org/live stream. So all of the different platforms the IOCDF has. The point of the live streams is to really give you education, resources, community. The live stream is only as good as the interaction, right? So all of you are on different platforms. I think people, when you're watching, you can only see who's watching and the questions on the platform you're on. We can see every platform over here. We really want to get to your questions, your comments, your statements. As we're opening and doing the open conversation, if you have an opinion on what we're talking about, please put a comment in the chat. I'm going to put some of those questions and those comments on the screen. Ryan and I will both answer them from both lived experience as well as clinical experience, as well as if it's just a topic or a comment, we can jump on that as well. So please feel free to be engaging, interact with each other, as well as ask questions live. Whatever platform you're watching on, please like or heart or share the stream. It gets more eyes on this, and that means more people are learning about OCD and related disorders. So please like it, please heart it, please support it. The only thing we can't do here at the IOCDF live streams is we can't step in and be your clinical intervention. We can't be a crisis hotline. We can't be your therapist. So please, if you're feeling suicidal or unsafe while watching this, dial 988 Lifeline or 988 or go to 988lifeline.org or find a clinician here on the iocdf.org/find help. So thank you so much for everybody for hanging out with us. I see we already got some people in the house. We have Georgia in the house. It's always good to see you. Nathan, good to see you, man. We also have YouTube in the house saying hi. Hello, Heather. It's good to see you. I hope all is well in your life. And Amy, it's always good to see you. Yes, it's good to see you as well, Spence. Thanks for saying hi. It's good to see you. Yes, we are so excited that Nathan is doing ERP, so that's awesome. We got SoCal, that's where I'm from. So awesome. Yes, it is good to see you, Riley. So it's good to see everybody. I see some questions already coming in, so I'm starring those, so I'll make sure that we get to those right as soon as we jump into Q&A. We're just going to say hi to a couple more people, and then Ryan and I are going to kind of have an open discussion, and then we'll get to your questions. So make sure to put your questions in the chat. So Ryan, I always run support groups, and kind of the topics that come up there always make me think like this is kind of the experience people with OCD and related disorders are having. And one of the topics that we talked about that I'd love to bring to this audience and get your perspective is, you know, some people were saying like, look, I've been in treatment for 3 or 4 years. I've made progress, but I'm going very slowly because I feel overwhelmed if I push myself too much. And so we really discussed kind of the pros and cons of moving at that pace, right? So moving at a smaller pace, maybe tackling smaller things. And I hate the word smaller because as you know, having these disorders, everything feels huge. But we all know that there's those bigger things out there, and there's those things that are a little bit more manageable. And some other people were talking about how sometimes when you tackle bigger things, it ends up being easier. A big discussion we talked about is, you know, if you have a 4-hour shower, sometimes going from 4 hours to 3 hours and 45 minutes and 3.5 hours is actually harder than going from 4 hours to an hour to 30 minutes to 25 to 15, because you're cutting out so many compulsions. And by not starting the compulsions, you're not spiraling like we usually do when we spend hours on it. So what are kind of your pros and cons of pacing? How do people figure out the pacing? And what are some of the things that you've seen with clients when they've made those big, huge leaps in treatment? Why are those advantageous?
A great question. We see this all the time, and I would agree with you that 100%. Sometimes going really small, when people think about it, it feels a little bit easier, more manageable. So maybe your anticipatory anxiety before approaching the exposure is a little bit lower than if you were going to take on a really big exposure. But it ends up kind of being like death by 1,000 cuts, we say. Like you're just kind of slowly doing this, and then it takes longer, and it's still so many compulsions, which we know compulsions make us feel some relief sometimes, but actually we don't really like doing them. They tend to make the problem worse. They reinforce it. So a lot of OCD and anxiety too is kind of tricking people into thinking they can't do certain things, or it'll be too hard, or something bad will happen. And we're really trying to challenge that with ERP. And I've seen almost in every single instance when someone says, you know what, I'm going to go for it, I'm going to do the big exposure, they always report, wow, I actually got so much relief from that. I'm so proud that I did it. I'm so happy that I did it. And we know that that's really where the relief comes from. There used to be, I'll say one more thing about this too, and curious what you think, but the word flooding, maybe you guys have heard this, is a concept where, you know, if you do an exposure that's too difficult, you will be flooded with anxiety or distress or whatever the kind of negative emotion that your OCD is associated with will come up. They've actually done research studies on this where they've compared kind of a more traditional graduated exposure hierarchy that goes slowly versus a flooding approach where you're kind of taking on higher level exposures on earlier. And the research shows they both work equally effectively, but flooding oftentimes takes a lot less time. And so you get the relief more quickly. I also think it's more reinforcing in this kind of self-empowerment aspect that, wow, you just did a really big exposure and it went well. People feel better about themselves, not just their OCD reducing, but their sense of self, their confidence, their empowerment kind of goes way up. So I encourage people to do flooding if they're willing to do it with response prevention. I encourage people to take on the bigger exposure, again, if they're willing to do response prevention, because it always leads to better outcomes.
Yeah, the way that I was explaining it, the analogy I kind of think of is I remember as a kid, we didn't do this a lot. My mom sometimes watches these, so she was not the kind of mom that would just say yes. But I think of it as like, I remember trying to like sneak things in the basket at the grocery store that I'd won. My mom would always figure out and like put it back, right? We weren't the type of family where my mom's like, sure, just throw stuff in. It was like, nope. But if you're having all these things getting thrown in your basket and you're only taking a few things out at once, the problem is it just keeps piling up and you're not making enough of leeway and headway towards combating the OCD. And so I think in the beginning of treatment, taking a slower approach may be what somebody needs, because you can't really learn in pure terror and panic. I come from a gym background, and so when we would train people how to lift, you start with the bar. And maybe you add on a little bit of weight so people really, really get the foundation. They get the proper, you want to focus a lot more just on form so that you're not hurting yourself. You're doing the lift properly. And then you just add on more weight. But the more weight you add on, the bigger you get. So it's the same kind of thing with OCD, is you may start with smaller things to get the form, to understand the treatment, why it works, how it works, and build up confidence and momentum. But once you got that rhythm going, when you start taking those bigger leaps, it means less compulsions. And I think sometimes people are trying to take a 45-minute shower down to a 30-minute shower without cutting compulsions, but just doing them quicker. And that's not going to work. So making those big changes and those big leaps really requires us to let go and give up some of those compulsions. And where the learning comes in is it's like, wow, I dropped like 15 steps in my shower and I don't really feel any worse after doing this a couple days. Or I'm not praying for 2 hours anymore. I've cut it down to 5 minutes and I still feel at peace, so really working on those big leaps. What are some gains? Like, what I always tell clients is once you make this huge gain, right, you're down to a 20-minute shower, 3-minute prayer, or you're only driving the direct way to work and not around because you're afraid of schools and stuff because of hit and run. It's like once you make those big leaps, people don't want to go back. It's easy to slide back if your, prayers went from 5 hours to 4 hours and 48 minutes, right? But if you go from 5 hours to 5 minutes, it's really hard to slide back. What are some big gains you guys have seen at your clinic where people are just not willing to go back because they've made such huge leaps and bounds?
Oh, yeah, no, exactly. I mean, all the examples you gave, I can think of people, kind of with panic around getting on the highway. And so they're driving, it's taking them so much longer to avoid certain roads or triggering spots. And then they just do the hard thing. And they're like, wow, I'm going to save myself so much time. Say that the shower is a great one. I mean, anyone with OCD who's had rituals in the shower or washing, cleaning rituals knows how agonizing they are. And then you don't even do them right. Sometimes you have to do them over again. It's so painful, the rituals themselves. And so being able to cut that out is just, it feels great. You feel so much better. You can actually maybe enjoy your shower for the first time in a long time. So 100%. I think a lot of times what we see when we're doing therapy with people, not just OCD, but really lots of different disorders, there's always this constant kind of back and forth between are we looking at short-term payoff or are we looking at long-term payoff, right? And so when you're making that decision about what exposure to go for, how much you're willing to reduce ritualizing, oftentimes if you're making the choice, I want to keep it small, it's because you're kind of, what you've got in mind is a short-term gain. Like I don't want to be too uncomfortable, or I don't want to push it too far, which in the short term, yeah, maybe makes you feel a little bit better, but it's coming at the expense of that long-term benefit, that long-term recovery. Challenging yourself and saying, I'm going to cut off an hour of my shower instead of 10 minutes might feel more difficult in the short term because you're like, oh my gosh, this is going to be really hard. What if it doesn't go well? I'm scared. But when you do it, the long-term payoff is so much bigger. And so a lot of therapy as therapists, and Chris, I'm curious if you feel the same way, right, is helping encourage people to keep the long-term more in the front of your mind than the short term.
Yeah, absolutely. I think that helps everybody, right? Like first having a why, like why am I even doing this? You know, you have to feel connected to some kind of thing that you're fighting for, but thinking about bigger terms. And I even talk to that with parents and loved ones and spouses that are supporting the person with OCD. And I say, look, like every time you give reassurance or every time you step in, you're doing it for the here and now relief, right? But the problem is the loved one is now learning that they can't trust themselves to do it, that they need help, and that, hey, my therapist is telling me this, all this fear is not real, but my family is joining in. Maybe it has some reality because they don't have OCD and they're joining in, right? So a well-meaning loved ones will jump in to provide that instant relief. But what I want the person with the disorder and the family and the loved one and the spouses and supporters to think about is like 2 years down the line, right? Like making these really difficult choices, challenging choices to handle things in the moment in a treatment way versus a compulsive way will have you have that relief. And, you know, I could speak on behalf of both of us and Liz and stuff. I would never go back. Like if somebody was like, hey, I'm going to wave a wand and make you go back to your worst times, I just don't have it in me anymore. I mean, I'm always shocked that I had the energy to do the things that I did. I mean, it was just brutal. Even just the rumination, right? Like spending all day in your head, actively worrying, actively concerned. The physical stuff was exhaustive itself, but never just getting mental rest. And even if I'm lying on a couch because I'm burnt out because my body has been doing compulsions 10 hours today, I'm just flipping and spinning and being negative and all that. So yeah, I mean, kind of thinking like, why am I doing this and what can my life look like in the future versus this instant relief that just reinforces the disorder in the first place.
100%. And I think, anyone with OCD it would totally resonate with the way you're describing it. It really is very all or nothing. It's like either your OCD is getting better, it's getting worse. And if it gets worse, it's going to be at a certain point, it becomes all consuming. It's all you can think about. It's all everything you're doing is directed towards that obsession, that fear, trying to make it go away. If you're not actively physically doing compulsions, you're in your head thinking about it or worrying about the next time you get triggered or what's going to happen. And so that's why we push for with ERP, like we don't want you to get from like 80% of your day OCD engaged to 10%. We want zero. We want full free. It's like a virus. If we don't eradicate it, it can come back. And I am 100% with you. If I think about going back to where I used to be with it, there's no way. My quality of life is so much better. And not just because the OCD is gone, but also because like I built so much confidence in myself going through the process of ERP and challenging these fears and the anxiety and what I learned about what I'm capable of. I wouldn't trade that for anything. So
Yeah, no, and I think about it too, right? Like for me, even today, it's like anytime I see little things try to come up, or maybe sometimes things that I haven't, like a lot of times what happens for me is if it's something that's like new or haven't done it for a while. And so, you know, it's been cool. Like movie theaters have always kind of given me the ick. I've discussed based OCD, and I've never liked like the feel of like buttery popcorn or like, you know, nacho chips with salt, and like, you know, they don't clean the seats in between each movie, and there's always like popcorn stuck or whatever. And it's so funny because everything you avoid, right, comes into your life. And I've never really liked the movies. I'm like, I'd rather stream it and not have a kid kick my seat and have somebody else like screaming at each other and like the crunching of the everything, right? But you know, a good friend of mine is an actress, and she hosted a last week she hosted a premiere of a film, and it was like a kids movie, so the whole place was sticky, popcorn everywhere, whatever. And it's just like, even now I'm like, no, I'm gonna practice what I preach, right? So it's like I'm not gonna take out some wipe and wipe the seat, or I'm not gonna like find, well, you can't really, you get assigned seats now, but I'm like, you know, I'm not gonna not eat because I needed my nachos and my pretzel bites. So I was like, I'm not gonna not eat because of, you know, having greasy hands throughout the film. And then I'm seeing someone, and we've been going to the movies a lot. They like the movies. And same thing, we went to see Scream 7, which was terrible, by the way. And it was like same thing, like sitting on the seats. But you just get to a point. I think what also helps me is like, what am I going to gain from this, right? Like I can get so much enjoyment being with my friends, being on a date, watching movies, having a good time, or I can sit here and worry about popcorn kernels, or I can worry about stickiness, and I can get in my head again, etc. So I think beyond just like, you know, fighting kind of for that future freedom, it's more than just freedom to me. It's freedom plus life and engagement. You know, I had a young client. I don't know if a client's ever asked you this, but I was like, this is way above my pay grade. But they asked me, they're like, what do you think the meaning of life is? And I'm like, whoa, whoa, whoa. I didn't sign up for this question. But when it finally came down to it, I was like, you know, I really think it's about the connections you make and the experiences you have. And the only time in my life I didn't have connection and experiences is when my OCD was extremely bad. I kind of disappeared from my family and friends. So I think for me, also part of this treatment is like re-engaging in life and getting that freedom. And that freedom allows you to then really thrive.
Yeah, I mean, that was so well said. And having a new relationship with yourself, getting to know yourself, your preferences, your beliefs, because you actually have time to think about things outside of your fears and your obsessions. It's like having a whole new relationship, not just with other people, but yourself as an individual. Love to hear that.
Yeah, real quick, because I want to get to questions. We're getting a lot. So we'll jump into questions. If you're watching in a second, please get those questions in. We had two other topics. We're not going to get to both, so I'll have to bring you back on for differentials. But one conversation that actually went really well with my group, and I'd love to get your perspective. You know, the way that this topic came up to group is one of the people in my young adult group was like, hey, I love this group, and I'm glad we always talk about OCD and related stuff. But right now I'm really going through some difficult kind of like friend breakups. Is it okay if I share that instead? And I'm like, of course, like I want this group. You can, you know, maybe something else is going on besides OCD, right? But it turned into a bigger conversation where people feel like so many of their real life stressors get neglected because of OCD. There are people in the adult group that I run talking about not getting to their taxes or they're moving and stress about that. My young adult clients are talking about like breakups and friendship breakups. And the overall conversation kind of came down to like having OCD makes it hard to face anything else. And people fall behind on assignments. They follow behind on work assignments. They're not seeing their friends as often. Their place is messy. They have headaches all the time, etc. How does somebody prioritize also giving some time to address real life stuff? Because I think people are so fixated all the time because of the nature of the disorder on the disorder and fighting it. But we're all whole people, right? Everybody watching this stream has way other problems besides just OCD and related disorders. So how can someone find some energy and balance that? And why is it important to kind of balance and address some of those life stressors outside of just OCD and related disorders?
Yeah, a great question. We see that a lot here too. I would say, I always try to tell people, you know, they'll say, oh, well, if I do that, am I just distracting myself from my OCD? And I always say, what could be a bigger distraction from your life than OCD? OCD is the biggest distraction, right? Like life is hard. It can be very hard. OCD aside, right? Like relationships are tough, school's tough, jobs are tough, families are tough, things are tough, right? Things happen, difficult things all the time. I want you to be attending to those things that really matter, that are meaningful, even if they're hard and challenging. OCD is distracting you from that. So a couple things I would say. Number one, let's use that as motivation to work really hard with your ERP, because the sooner you can get OCD under control and get freedom from that, you're going to have so much more energy and time to go and attend to the things that you really need to attend to, those other challenging things. Now, no one's expecting you to be able to knock OCD out in a week or something, right? So yeah, it is a balance. You want to make sure that you kind of maybe talk to your therapist about what would a healthy schedule look like, where you can kind of schedule in time for ERP to really stay proactive with OCD, but then that also leaves you time to manage those other things that are really overwhelming: moving, changing schools, transitioning, relationships, stuff like that, managing health concerns. It's a lot. It can be a lot. But I think being proactive with ERP on kind of a daily basis can help you stay ahead of it, so that it's not overwhelming you and taking you away from the things that you really want to be putting your energy on.
Yeah, the other little trick, and I don't know why it's not talked about more, but one trick that I do with clients, because I found it really helpful after therapy, is finding ways to infuse your treatment in everyday living, right? So, like, I'm not like in treatment anymore, but going to the movies is a time to practice that, right? Like, I don't have to schedule 30 minutes to like eat. Well, I eat chips all the time, so that's why I'm like, I'm better with the chips than the popcorn, because I don't even like popcorn. But it's like going to the movies or something on a date versus having to sit at home, eat popcorn for 20 minutes and block out your life, or if you have to go to the post office to mail stuff for documents, use that as an opportunity to open doors and touch handles. If you have scrupulosity based fears and you go to a church group on Wednesday and on Sunday you go to church, using that as an opportunity. So sometimes using it in everyday life helps, because then you don't have to really sort of schedule things out. And people will sometimes say, wow, I'm really exhausted from OCD and then the treatment and I have no time for anything else. I'm like, well, how can we combine stuff? If you have harm fears in public and you also have errands to run, fuse them, right? You don't have to go out in public and like do harm exposures, then go do errands. Do them together, right? You can kind of knock both of those things off.
Great point, and kind of reminds me of the best ERP is 100% values-based, values-aligned ERP, which means that it is going to be integrating with things that are in your real life, things you care about, things that are relevant and important to you. So there's that natural overlap, and they're not separate. They shouldn't really be separate.
Yeah. I'm going to jump into questions and comments. I know you guys run support groups. I agree with Ash. I run support groups. I have long days, Tuesday and Wednesdays. Like Wednesdays, I'm here all the way until like for 12 more hours of work with clients and then group. But the reason I run groups for me is because it's the only time you're surrounded by people that get it. That's why I still do these live streams and love these live streams, and hopefully they'll let me do them until I die. But for me, it's just because having people in a room, like I picture everybody watching and commenting, we're all in the same room together. What do you see in support groups, and why should maybe some people watching, if they can find low cost or free support groups, why should they seek those out? What do you see those really help with?
The community. I mean, the community is so important. Building connections with other people, people who understand what you're going through, people who can encourage you and support you positively in your journey to recovery, can help help hold you accountable. You hold them accountable. There's this sense of responsibility to each other, in a shared struggle, a shared understanding. I mean, I can't tell you how many times, we do a residential program. So people here, when they come live at the clinic to do their treatment, they always talk about how the community of being alongside other patients who are struggling with OCD is so meaningful to them. To see other people or hear other people talk about ERP, doing exposures that they were terrified of, how hard it is for them, and then seeing them do it is very inspiring. It's very encouraging. And so I think you really just can't emphasize enough the importance and the value of having a community, a supportive community. And I think those support groups are really the best place, oftentimes the best place to get that.
Yeah. Some people are sharing their thoughts on the meaning of life. So love and kindness, and to be encourager. Please be nice. I always think about that too, is like my papu, which is grandfather in Greek. My papu was so sweet. He's like the nicest human being, like one of the nicest people ever. And I remember at his funeral, it was like standing room only, packed, people out the door because he was so kind. So I always tell people like being kind always, pays off and things like that. Ash says the meaning of life is finding personal fulfillment amid uncertainty, especially for us with OCD, for sure. So I'm going to ask you, what do you think the meaning of life is? I know that's a very heavy question, but
yeah, well, it's funny you mentioned that, because I think as therapists, even though we're kind of in the OCD anxiety world, it often comes up. Like people are kind of, as they're working with this, it comes up, as a part of the process of like, yeah, what is all this about, right? Like what do I want my life to be? What do I want my life to mean? Personally, and because I think about this a lot, especially with our work, I think it's about becoming the best version of yourself. And that's through growth and change and challenging yourself and hard work and reflecting. And yeah, I think that's my take, is we're here to become the best versions of ourselves, whatever that means, whatever that looks like to you, whatever that vision you have for yourself. And so yeah.
Yeah, personal growth. I want to put this comment up. So Chris worked at a movie theaters, and said like, they cleaning the seats was always hard to do in time. There wasn't enough time, so they really focused on sweeping. But this brings up a bigger topic, right? So when you have contamination, and it could be any subtype, because there seems to be perfectionism weaved into almost every subtype. So when you have contamination, there's this idea like they should clean. I've had clients say it to me, right? Like they should go through after the theater and clean every single seat and wipe it down with some kind of like antibiotic and make sure that it's clean, and not just sweep the floors, but should actually spray like cleaning chemicals to clean it. Then one of my other clients because it was in the group, was like, no, not cleaning stuff, because then I'm going to get a disease. So, you can never make an OCD happy. But one thing I try to teach clients with contamination, because it's a reminder for myself, we don't need to be that clean, right? Like, I don't need to be that clean, unless I do want to, put out there are people out there that do have real autoimmune diseases, have to be a lot more cautious and careful. So shout out to those people. I'm not talking about for those people that may need to take different precautions, but in general, right? Like, I don't need the seat to be spick and span. Like, the back of my shirt might get a little bit of popcorn salt. I'll live, right? And I think that's one thing that people have to kind of do in OCD. Also with like purity of thoughts, right? Like, I need to only have good thoughts. You're not, and it's okay to have bad thoughts. So how do people kind of make space for the uncomfortable when tackling any subtype of OCD?
Yeah, no, great question. And I think kind of what you're getting at is really important. Are you still kind of holding out that the world is going to change, the environment is going to change, so that your OCD doesn't have to be triggered about something? Because if that's the case, you're going to stay stuck there, right? And I think a big part of recovery from OCD, a big turning point people have, is when they get to a place of, okay, well, I'm accepting that, like, I'm going to have to get comfortable being uncomfortable with this, right? Or this level, this type of trigger, or this thought that feels contaminating or unpure or something, right? Like, when you can get to that place where you accept, hey, my brain is my brain. It's going to flood me with intrusive thoughts sometimes, and I don't have to like them, but like, that's what my brain's going to do. Holding out hope that one day my brain will stop doing that. It'll stop being a brain. All normal brains do that, right? Or that some medication will stop me from having these thoughts. Like, you're going to keep waiting and you're going to stay stuck. But once you can get into that acceptance mode of like, hey, the world is going to feel dirty and contaminated and unclean, and my mind is going to have crazy thoughts, and strange things are going to pop up, and uncomfortable thoughts, and that's okay. Like, I'm okay with that. You're already well on your way to recovery, just getting to that place mentally.
100%. I could tackle this first, and I'd love to get your perspective. So Sadie asked basically, like, why does it feel so wrong not listen to OCD? I feel horrible when I don't listen to it. Yes. So what I want you to think about, right, is OCD doesn't like create a new section of the brain. OCD really impacts the overactivity in parts of the brain that keep us safe. So I'd love to have like a neuroscience scientist on to go into more depth, but of the knowledge that I have and that I know is we have these amygdala. They're these two little almond-sized pieces in our brain, and they kind of call them like the fear center of the brain. And their responsibility is to really kick that fight or flight part of our brain into action, which is more of the reaction part of our brain. When the orbital frontal cortex, I think of it as like the lookout tower, spots danger. So in real life, not OCD life, but in real life, if I'm crossing the street and my eyes kind of witness a car sort of speeding, they have a red light, I notice the driver is looking down, the frontal cortex is like, hey, Chris doesn't need to like make plans or do art or, talk to someone right now. He needs to be safe. And so the amygdala is like, yes, sound the alarm. The limbic system goes on fire, fight or flight kicks in. And then I can sort of like turn, pivot, and jump back on the street so I don't get hit by the car. So it's almost hard to not give into it, because not giving into it would be just standing there and getting hit. Now, the problem with OCD is it puts us in the mindset that we're in dangerous situations like that when we really aren't, because that reaction, fight or flight or freeze part of the brain, is supposed to be a really quick reaction, right? We see our little nephew fall in the pool and you run over and scoop him out, and then you're back calm a few minutes later, you're kind of all laughing, you talk about, pool safety. With OCD, people can be in that fight or flight for hours with rumination and compulsions. And so Sadie, the reason it feels so horrible not to listen to it is because it basically is going against biology. You're ignoring the part of your brain trying to keep you safe, and your brain is like, well, you're going to die, and then you can't reproduce, and then the species is going to end, right? It kind of goes to that more reptilian prehistoric part of the brain. So that's why I always tell clients being more proactive in treatment can put you in those situations OCD says is dangerous on your terms, and you can kind of practice sort of engaging in different behavior to reteach your brain, like, this isn't a time that I need my fight or flight or I'm not in safety. But that's why it's so hard. You're kind of going against sort of your natural ability to keep yourself safe.
Yeah, exactly. That's so well said, right? It's kind of like the wires in your brain get crossed. What's supposed to be labeled as safe is kind of labeled as dangerous. What's supposed to be labeled as dangerous is sometimes labeled as safe in terms of avoidance, perhaps. And so we're really trying to, through exposure therapy, we're uncrossing the wires. We're kind of retraining your brain. And we know through, like Chris was mentioning, kind of neuroplasticity, the brain is able to change itself, which is so amazing that we have that ability. And exposure therapy is really harnessing the power of that to uncross those wires so things that are safe don't feel dangerous anymore. But in the process, it is going to feel that way. Sadie, what I would tell you is, if you've been diagnosed and you know the types of difficult feelings that OCD is going to bring up when you're triggered, once they come up, we're going to do what Chris said, like opposite action. Okay, I know my brain is firing and telling me this is dangerous, but this is my OCD. I'm triggered. I'm actually going to approach it. And when we do that, our brains can learn, and oftentimes pretty quickly, because part of that neuroscience is that our brains are designed to learn quickly when something we're afraid of isn't actually dangerous. We have that ability. That's why like phobias can be sometimes reversed in like one session or two sessions. If someone's afraid of dogs, they approach dogs in a healthy way without safety behaviors or avoidance, and their brain learns like, oh, dogs aren't dangerous, right? OCD is a little more complicated than a phobia, but it's very similar in terms of the brain chemistry. And so our brains can learn new things, but it's difficult. It's really hard because they feel dangerous, but we can teach our brains that they're not.
Exactly. What I wanted to add to this, Christopher, asking the question, last week we did a live stream with 3 top experts in trauma, PTSD, and OCD. It was Dr. Lauren Wadsworth, it was Dr. Caitlin Pinciotti, and Dr. Nathaniel Van Kirk. All of these live streams can be rewatched either if you go to Facebook and you go under Reels or Live. Reels. It used to be videos, but now it's Reels. You can see all these live stream back, or on YouTube, if you go /IOCDF, you can watch that. So it was a full hour on that, because there are certain adjustments you may need to make, because sometimes, you wouldn't use ERP to treat trauma. And sometimes it's really important during an assessment to figure out what is trauma, what is OCD, and make sure that you're not kind of conflating them. That was a big message I got from last week's live stream, is not to conflate the two. Like they're different. I don't know if you have anything that you want to add in.
Yeah, I would say, if you do have, trauma or PTSD, you want to work with a therapist who is trained in treating that and has specialty with that. And if you've got both OCD and trauma, you want to find someone who treats both. And there are lots of therapists that have training in both, because it can be a little tricky, but absolutely you want to get the right specialization so you can get the right treatment.
Yeah. This question was asked on YouTube. It says, can you advise how to implement ERP for magical thinking and mental contamination OCD? I've been really trying to improve. So obviously ERP is ERP, but if somebody has more mental focus compulsions, like they have like mental contamination. So I have a client with that. It's kind of like if they see certain content they don't like, it feels like they're, dirty. They kind of have to reverse it, or they call it offsetting. Also magical thinking, right? Like I can somehow control or cause things to happen, even though there's no correlation. What would be sort of like the strategy somebody might take in this situation?
Yeah, great question. I mean, we see this a lot. It's, in some ways, I would say almost all OCD has some element of magical thinking in there somewhere, some more prevalent than others, but it's very, very common. Mental contamination also pretty common. And so, ERP really is going to look very similar. What are you trying to keep safe? We have to contaminate what you're trying to keep safe. If that's your mind or certain thoughts or certain memories, certain images, the ERP is going to be purposely contaminating it, right? Magical thinking, whatever your OCD is telling you, the bad thing's going to happen if you do this or don't do this. We're going to ask you to do those things, right? We're going to really lean into challenging the thoughts, the fears, and do so directly, and then removing any safety behaviors you might have, rituals, compulsions. If it's mental contamination, there may be some, a lot of mental compulsions. We're going to try to figure out exactly what's going on, which ones are you doing, talk about how to stop doing them while we're doing the exposure and afterwards. But it'll look very similar to kind of traditional ERP. It's just maybe a little more abstract because a lot of this is happening internally.
Yeah, I always remind people, like, if you can almost imagine, like, you're trying to make sure the O doesn't turn into a C. So if I have an obsession, let's say, if you want to go into more depth on what your mental contamination is, I can use specific examples in the comments. But, let's say um, I scrolling on TikTok, because this is what my client does. I scroll on TikTok and I see some kind of image that I don't like, right? And my brain is like, "Ew," it's almost like more like a feeling, right? I don't like the way that it feels to have that image in my head, that kind of content. I want it to be good. I want to neutralize it, right? That's the obsession. Like, come on, Chris, like neutralize it, get safe. You don't like that content. If I make it a compulsion, that means I'm trying to reverse it. Maybe I think of a good thought. Maybe I shake my head. Maybe I imagine like that video 5 minutes before that video, whatever it is, count. There's different mental compulsions people do. What you're really trying to do there instead is to not engage in that. So it's a lot of times more abstract, because if I have to get up and go wash my hands or sit down and pray, there's like an action, right? And it's easier to kind of note when the obsession turns into compulsion. But mentally, if you have this kind of feeling of contamination mentally, and then you're trying to do something, that doing something about it is the compulsion. So that's what you're trying to disengage with. This question is a good question because a lot of people get it. So this is someone trying to get their son OCD treatment for scrupulosity, but the filling out forms, FMLA are some roadblocks. A lot of people with OCD struggle with paperwork. I can't speak for your clinic. Maybe you can. I mean, I know like for us, right? I don't know if this gives the person asking the question some insight. I mean, just legally here in California, we have to get certain paperwork because as you become a potential client, we have to have emergency contacts. It's, just to keep your son safe. And we totally understand. So some people will fill them on digitally if that's easier. A lot of like we use Simple Practice. A lot of different systems now use digital paperwork. Some people like to come in and fill it out by hand. Sometimes people have a parent or a guardian fill it out, and then the person just has to sign that somebody else is filling it out for them. Sometimes I've had clients come in and during an assessment, I'll fill it out for them. They just tell me the answers. So I would see, just ask if there's a workaround. Obviously, if it's OCD based, one thing I work on over time is to get a client to be able to challenge that. But in the beginning, if I have to help or support so we can get treatment started, I would just ask to see. FMLA paperwork typically we can fill some of that out, but some of that has to be filled out by you guys. And so that's more of a government thing. I can't really help with that.
Yeah. Not much for me to add. Kind of basically what Chris said. Same thing. If it's OCD related, then usually the clinic or the therapist will be able to suggest some ways to help support, whether that's family or the therapist themselves. But the forms, oftentimes our hands are tied in terms of needing them for legal purposes, like Chris said.
Yeah. How do you work with clients who have a fear of breaking rules, either accidentally or for a possible justifiable reason? I struggle with response prevention for this.
Yeah, we see this a lot. This is always a fun one to do, rule breaking exposures. But yeah, I mean, we're going to ask you to do the thing that you're afraid to do. I mean, obviously, keeping you safe. We're not going to ask you to do anything, gravely illegal or that would put you in actual harm's way. We always say we're never going to ask you to do an exposure that we wouldn't also do. But oftentimes, patients with a fear of breaking rules, there's usually a lot of like scrupulosity around it, or interpreting the rule very rigidly without flexibility, or there's some kind of magical thinking behind it. So it can look a lot of different ways, but we are going to ask you to do that, to break some rules, and that can be really actually fun to do for people that have a fear of it, and we can get really creative with how we do it, and it can be really, really helpful.
Yeah, what I always remind people is you don't have to like go break the law to learn. I think sometimes, people treat OCD treatment like fear factor. One of my clients and I went to Costco. I think Costco is universal, right? You guys have them in Texas?
Yep.
Okay. I always forget what's California, what's not. I mean, I feel like Costco, everybody has a Costco. They had a
Yep.
Costco in Iceland, so I think everybody has Costco at this point. But like a client and I walked into Costco, and the person at the front wasn't paying attention. Neither of us had like a pass, and we just kind of walked around, tried samples, and then went up the front to buy something. My grandma at the time had one, and I tried to use hers, and they're like, "Nope, you can't use it." And I was like, "Okay," and we left, right? And so we're not going to get arrested. I don't think, whoever you believe in, whatever God you believe in, if you do. I don't think that's going to be sinful, right? Like, it was just one of those things where it was enough to practice, right? We didn't have to like go rob a bank to learn. I think that's a big part of it, is like, what comes up for you consistently? What are the rules that OCD thinks you're breaking? How can we recreate that? But it's more about the learning. And what I was trying to teach this client is that, you know, sure, you don't have to break rules, but at times you might, or there might be a justifiable reason. And did all the fears that you thought were going to happen? No. They just were like, nope, sorry, you don't have a card. And we're like, oh, bummer, we'll go somewhere else. And that was it. Versus like everybody arresting us. We're going to jail for trying to buy, I think we're trying to buy Gushers or something. So, just realizing like the outcomes aren't as bad. You had mentioned flooding earlier. And so somebody asked, how do you draw a line between flooding and then like fear factor treatment, where it just becomes, where a client just feels like it's grueling, like they're just being hit left and right. So how do you kind of draw the line between those?
Totally, yeah. We don't do fear factor approach yet. Fear factor would be doing something extreme just because it's extreme, or the idea that you're really overcorrecting for the fear. So something would be like if someone has kind of typical disgust or contamination based OCD, and so their fear factor would be you lick the toilet seat, which by the way used to be a thing, or you eat things off the toilet seat. We don't ever really do that anymore, because why would you do that? No, like, people without OCD aren't licking toilet seats. They're not eating things off toilet seats. That'd be an example of like a fear factor exposure, which I would never endorse. Now, flooding might be if someone comes in and they're currently, they're not sitting on toilet seats. They're putting lots of toilet paper down or plastic on top of it, or they're standing or squatting. They don't want to touch the toilet bowl at all, the seat at all. And they might say, well, the first exposure that I would do gradually is, instead of putting, 5 layers of toilet paper down, I'm going to put 4, right? Okay, you could do that. That'd be an exposure. You'd be removing some safety behavior, some rituals. Flooding might be, we're just going to sit on the toilet seat. Like, we're just going to sit on it fully. No rituals, no barriers, no avoidance. And they might say, well, no, that would be too much for me. That'd be like, that's my 10 out of 10 on my hierarchy. But the goal is for you to use the toilet normally. Like, that's the end goal. Now, we could get there by doing lots of smaller exposures gradually leading up to that. And that's fine, by the way. That works great for a lot of people. We could also just go to flooding, which would mean not extreme, like we're going to have you eat off the toilet seat. It's just sitting on the toilet seat. You have this OCD's telling you you're going to flood. There's going to be so much anxiety. You're going to panic. You won't be able to handle it. But maybe you will be able to handle it. Maybe it actually will be a lot less difficult than you're thinking. Oftentimes, removing the rituals is actually, you feel less anxiety. Kind of paradoxically, a lot of OCD treatment is very paradoxical. So anyway, I'm not saying flooding for everyone, but you're right. Consensual agreement. I would never force someone to do that. I would kind of explain what flooding is, explain how it works, and say, what do you think? What would you like to try? You always give the patient, we want them to be kind of leading the treatment and agreeing to what they want to do. But if someone says, you know what, I really want to try to knock this out more quickly. I do want to challenge myself. I want to try it. Let's see how it goes. I'd say, okay, this is what you'd have to do in terms of response prevention. If they say, I'm willing to do that, I think I can do it. I said, let's do it. Let's flood, right? And so that's the difference, if that makes sense, between fear factor, which we don't endorse or approve or do, versus flooding.
Yeah, I think like I had a client who, he hadn't opened like a door handle in years. He would stand there and like act like he's on his phone and wait for somebody else to go through. And like, my IOP with clients, I'm working one-on-one for 3 hours a day. And he was like, can we just go to the mall and like open every door they have for 3 hours? And he did. And then on his own for homework, he went out to his local mall and stores and opened handles for 3 hours, opened them at home. We did it again. So what's technically flooding? You're spending like 7 hours a day opening door handles, but it wasn't like he was licking door handles. He wasn't like, going to the inner city where there's drugs and stuff and opening door handles. It was just places around his house, right? So that allowed it. I just feel sad. I just wanted to put this up for Sadie. I'm so sorry. I don't know if you have words for encouragement, but I know, getting ready to do treatment and then the therapist needing to reschedule, but we're glad you're here. We're glad that you're here. And hopefully we can't be as good as a therapy session, obviously, but just,
Yeah, hang in there.
Yeah. How do you feel about this? I saw this and I was like, Nathan said, I just wish they could come up with a medication that'd make it go away in complete remission. Somebody asked me this the other day, and they're like, would you be sad as an OCD therapist? And I'm like, well, I would have to change careers, but like, if that meant we just wiped out OCD, I would be fine. I would,
Yeah.
like, I don't want people to suffer so I can have a job. I would go to school and do something else. But Amy had said, like, but then you won't get the skills. It always makes me think of what Jonathan Grayson says, and we were talking about that in group yesterday as well, is like going through OCD treatment. If you really look at the core, and it's why when people attack ERP, I get very defensive, because at the core of ERP, what it's saying is like, hey, there are some challenging things in front of you, and you feel very small, you feel very overwhelmed, and to make these challenging things go away, you just want to avoid or maybe compulsively act, right? Treatment is saying, no, but you're big, you can handle these things are manageable, let's face them in a systematic and collaborative way, let's overcome that, let's gain some new skills, let's sit with uncertainty, right? Because you have uncertainty in other aspects of life. If you choose to go get a job or interview for a job, you may or may not get picked, right? If you get a job in New York, you might have to relocate, and who knows if you'll hate New York, etc. Getting into a marriage, you don't know if it's going to go well, or starting a family, right? So the core components of ERP are so applicable to other aspects of life. So that's why I'm like, I don't know if I would have been, my life would be like, if I'd be as much of a risk taker or other things if I didn't go through treatment. But maybe I'm just talking out of my butt, and if I could go back in time and just take a pill, I would have wanted it. So I was just curious to what your thoughts were.
I would agree with you. I often think about this, but I think that a lot of my life was really severely compromised by OCD, being untreated, and not understanding it and not being ready to deal with it, which is terrible. And so I think back, I'm like, man, yeah, of course I would take this. If this like miracle medication was there, I would take it. But then I think about, yeah, but since I've been in recovery from OCD, all of the positive changes in my life have been a lot, no exaggeration, a lot of it has been as a result of the work that I did that was unrelated to OCD, but was a direct result of the what I gained personally from having gone through ERP and learning, like, oh, wait a second, I want to make decisions that I care about, that are important to me. And it's not just about making myself feel better, choosing comfort or choosing, short-term relief. And then it's interesting, once I did ERP for very specific OCD obsessions, I then realized how much other parts of my life I was compromising or not putting what I really wanted first, because I was like afraid. It wasn't an OCD fear, but it was just like, yeah, I'm just gonna not do that because I don't know, maybe I'm afraid of failing, or maybe that'll be really hard. But ERP taught me it's okay to fail. Actually, you'll learn something from failing. Actually, it's okay to be afraid, but that's it. Doing it afraid, there's so much more value in it. You're going to feel so much, it's going to feel so much more meaningful and significant. And so it's like, yeah, would I trade that? I don't know. It's very hard to say. It's a good question though.
Yeah, I have obstructive sleep apnea, and if I had to choose one, I would take a pill for obstructive sleep apnea way sooner. It is so life consuming, whereas I feel I have so much more power on facing the OCD. But if there's a pill for both, I don't know. We'll never know, right? I'll go back to that one. Oops, this is the one I meant to put, and then I'll go back to the other two. Is there any surgical operation for brain to avoid bad thoughts? Medicine isn't working. It seems not to help them or whatever. Definitely go back to any of our live streams with a clinician, with a psychiatrist. We always have psychiatrists on every second Wednesday of the month. As far as I know, there isn't any surgical operation to just avoid bad thoughts, right? I mean, we know that people, even without OCD, have negative thoughts. They have intrusive thoughts. Obviously, we have other interventions outside of medication. Transcranial magnetic stimulation, TMS, is something that people are using, and some are finding it helpful, some are not. Same with DBS, or deep brain stimulation. I know Liz McIngvale has talked about that. So there's other interventions. We're looking at psilocybin. Obviously, that's very, very premature in the research and things. So there's other stuff outside of medicine if medicine isn't working. But I don't think there's any operation to just not make us have bad thoughts. It almost sounds like a scary movie though, right? Like where you only have good thoughts.
It's like a sci-fi.
Fine.
It's like a dystopian sci-fi film. Yeah.
But I love your name, Optimistic Man. Look, like I said, I mean, my hope one day, would be that we come up with some way to zap OCD out in minutes, right? And Nobody has OCD anymore. So I love that. What you might want to do, optimistic man, is next week I have a psychiatrist coming on, and you could ask that question. She would know way more than me. She's a psychiatrist at USC, so she would know more about something like that. Somebody asked about overcoming insomnia and intrusive thoughts after stopping medications. I got these issues. I would say first and foremost, if anybody watching has insomnia, it could be medical or it could be as a result of OCD. If your insurance covers it, please get a sleep study. They can see like if insomnia is actually medical. It's only medical about 25% of the time. Typically, it's something more mental or sleep hygiene. I would definitely ask this question next week with the psychiatrist to see if there are some medications that once you stop it, suddenly you get insomnia and more intrusive thoughts. My guess, though, would be, the medication was probably helping with sleep and combating the intrusive thoughts and maybe getting off of it. Kind of, I know for some people when they get off their medicine, maybe they have to get off because they're pregnant or for health reasons or whatever. The noise gets loud again and it's trouble to sleep because you're laying in bed thinking all day. So I'd get a medical workup. I'll toss this one to you, Ryan. My theme lately is sickness and dying with my pets and loved ones. I want to be in the moment and live life, but OCD keeps me stuck. So how does somebody live and thrive when they're getting repeated thoughts about sickness and dying? Two topics most people don't want to think about, right?
Yeah, that's a tough one, but I would say kind of back to the example you gave earlier, Chris, about kind of pairing ERP, your exposures with things that you actually want to be doing, but OCD is keeping you from doing them. So I would say, I want you to spend lots of time around your loved ones and your pets, and let's actually think those thoughts while you're with them. And then you'll show OCD you're not afraid of having those thoughts and feeling that way when you're around your pets and loved ones. And a product of that is you'll get to spend more time with them and you'll feel good about yourself for that. And they'll probably really enjoy getting to spend more quality time with you. So it's like it's a double win here. You've got you're spending time with them in a helpful way is going to treat your OCD, and it's also going to move you closer to the life you want with the people that you care about.
Yeah, 100%. Somebody said that TMS was really life-changing for them. I think that's awesome. I've heard some people didn't find it helpful, but some people it's been life-changing and it's so important. Yeah, Betsy, I can go a little bit more into this. A lot of times one of the things I see working at a higher level of care is a lot of people do really well in their treatment provider on working on physical compulsion. So let's say, they have a thought that they might harm their family members. So, they might spend time avoiding that family member, or they might ask the family member, do I make you nervous? Do I seem like I'll hurt you? Right? Like that's a very clear O becoming a C. But there's people that never do an outward compulsion, right? So a good one is like people that are afraid of having heart attacks, right? The O is like, wait, does your heart feel weak right now? Do you feel like you're having a heart attack? And then they start to kind of scan their body. Do I feel like I'm having a heart attack? Or maybe they have some magical thinking like, okay, I'm going to think about my heart being healthy. They don't realize that's a compulsion. And also, if they had the obsession, they may have a heart attack at 8 a.m. and it's 5 p.m. and they're still thinking about heart attacks. That's been a compulsion all day. And I think when people treat mental compulsions as obsessions, they read the literature and are like, oh, it's an obsession, I'm not doing a compulsion. No, keeping it on the tip of your brain and rehashing it and spinning it and scanning are all compulsions. So I think that's so important for clients to know and for you to know, so that if you're doing great by not doing physical compulsions, but OCD is still hitting you pretty hard, it's like, oh, that's because mentally all day, all I'm doing is spinning, thinking about my heart. I got to stop that, right? There's other things to engage in life and focus on. And until I start to feel sharp pains, which is an incident, that's the difference between OCD and not OCD. People without OCD wait for an incident first and react. We try to create every possible incident and then react even though it's not there. So that's why it's so important to know the difference. Ryan, I'm going to give you the final thought. We only have about a minute left. What are some final thoughts you want to leave with these good folks? Any kind of like message of hope or something to think about, or something that you think will kind of just help them kind of tackle the rest of the day?
Totally. Well, first off, this was super fun. It's always great to talk to you. Yeah, you mentioned we've met each other before, and Chris is just as fun in real life outside of the webinars as he is on the webinar.
Thank you. Right. Could you imagine I'm really like lame in real life? Just like boring.
Not a chance. Not a chance. But yeah, I would just want to say, I hope that the takeaway is one of hope, given that Chris and I both have lived experience with this, Liz has lived experience with this. Our clinical team here, I want to say like half of our clinicians have their own stories with OCD or some other type of anxiety disorder. And so like recovery is possible, freedom is possible. And what I love about ERP is that ERP, if done well, it's not just recovery from OCD, but it's also moving you more fully into the life that you want, to closer to the things that are important to you, and building your sense of self, your sense of self-esteem, self-confidence, self-efficacy, that you can do hard things, that like Chris said, you're bigger than your OCD, you're bigger than the challenges that life throws your way. So it really is a message of hope and optimism. And there's a community here of people that have been through it, that care about you, that believe in you, and that want to encourage you and see you get better. So please, please, please get connected. IOCDF, OCD trained therapists, support groups, whatever that looks like for you. But please, I wish you all well, and take hope as the message here. Freedom over functioning.
Yeah. My final thought is I'm just going to answer Mary Beth's question. The way that I helped envision my future life and something that can help with her son is we just went to the drawing board. I finished treatment at a blank life. I had nothing to do all day. So I kind of, we talked about getting me involved in things that I used to love, not this like high pressure, go get a job, move out. I got back into animal shelter, at an animal shelter. I volunteered there, tennis, martial arts, learning Spanish. I just started kind of getting back engaged in things that at one point brought me joy. I started getting different belts in martial arts. I started to get a job at a gym. I got my own dog instead of volunteering there. I started to learn Spanish, right? So just trying to figure out like what are some small things he can get back into that will make him happy. Thank you so much, everybody, for joining, for engaging in the comments. Once again, this is your live stream. We got so many questions. I didn't get to all of them, so I apologize. Please come back. We'll get you in a future live stream. But we're here every Wednesday for Ask the Experts at 12 noon Eastern. Next week, we're going to have a psychiatrist on, which is always super exciting because they can answer all your medical questions. But if you don't really have any medical questions, still come, because I'll be there to answer your clinical questions. And I hope to see you every week. A big shout out to Ryan Judd. Thank you so much for coming out. I love that Liz always sends really good people. I love people with lived experience as well, so you can answer from both perspectives. I appreciate you sharing your knowledge and your time with everybody watching, and we have to have you back. And thank you.
Please do. Yeah, good to see you, Chris. Take care, everybody.
Yes, take care, everyone. Great seeing you. Have a great rest of your day. And, make sure that you head over to the iocdf.org/find help to find a provider that can support you. Take care and have a great rest of your day. Bye, everyone.